have a talk on meniscus repair principles and techniques. Just a brief overview of anatomy. This is the right knee, and the neurovascular structures are very close to the midline, slightly lateral to the midsection of the knee, and just posterior to the posterior horn of the lateral meniscus. So it bears an importance in the fact that we need to choose the type of repair on the basis of the site of tear. These are the zones of tear, zone 1, zone 2, and zone 3, as discussed already. I just want to highlight here that these are the circumferentially arranged fibers, and we don't want to disturb these fibers while we are selecting the type of repair. And these are several types of tear already discussed. There are several factors which prognosticate the type of, which prognosticate whether or not the meniscus is going to heal. And I just want to highlight on these factors which tells us about the principles of repair. This can be summarized in three ways: A standing for anatomic reduction, B for biological augmentation, and C for circumferential compression. The anatomic reduction is very important because we first want to make sure whether or not the meniscus is reducible. Once we find that this is reducible, then we go for repairing this meniscus, and this can be done by help of trocar or also with the help of probe if the tear is very small. And biological augmentation is the method in which we increase the potential of healing the meniscus. This can be done by several ways. Mechanical stimulation can be done with the help of the saber or with the help of the rasp we have. We actually rasp the raw surfaces of the meniscus, or we can also rasp the synovium so that there is angiogenesis. There is it also stimulates the fibroblast on the torn part. Another way of biological augmentation is marrow venting procedure. In this procedure, we actually make the veins. We stimulate the non-wood-bearing part of the condyles, which stimulates bleeding. The blood has the mesenchymal stem cells. It has the marrow, which stimulates healing of the meniscus. Another way is trephination. In trephination, what actually is done is we create a tunnel in between the vascularized portion and the avascular portion, so that the blood flows from the vascular portion, and it again leads to release of different growth factors. Several other ways of stimulation, augmentation of fibrin clot. We use the autologous fibrin from the same patient and deposit this fibrin clot on the torn part, which again stimulates healing. PRP, stem cell. PRP is becoming more popular these days, and stem cell is considered promising, but we don't have this in our country. We can see the articles, we can see the evidences from other countries. The basic principle behind biological augmentation, it may be fibrin clot or it may be PRP, stem cell, is risk of delicate and several growth factors like fibrous growth factors or platelet-derived growth factors. And these again lead to the proliferation of fibroblasts and chondrocytes. And another thing, the metalloproteinases and aggreganases that are present inside our knee, they these already torn meniscus. And the biological augmentation inhibits these enzymes, thereby the degeneration of the torn meniscus. And the third step is circumferential compression. This compression, of course, what it does is this retains the reduction of the meniscus. And this is not necessary that the ABC should go in this order. Sometimes we go for anatomic reduction and then circumferential compression, and then we can go for the augmentation like the fibrin clot. And there are several types of meniscus repair: all inside out, outside in, and then hybrid. Hybrid is the combination of one or more techniques, And we choose the type of repair on the basis of the location of the repair, on the basis of comfort of the surgeon, and also on the basis of the availability of the resources. All inside techniques, we need an anchor-based device with pre-tied slip knot, and this has calibration at the tip, and these are the anchors loaded in this device. And these anchors are like a fish hook, barbed fish hook. Once we fire this anchor, this lies in line with the capsule so that it cannot be retrieved back. Then we fire at another side, and this anchor lies again in line. That means in parallel with the capsule. This is the capsule, this is the skin, and this is slip knot. The slip knot is pulled and then cut at its end. Once it's fired, suppose if this is misfired, the entire anchor is gone. This becomes useless. And these anchors, they lie just outside the capsule. This is like a fish hook, so it cannot be retrieved. So the disadvantage is this is more expensive. This requires expertise. And the advantage is this with the help of this technique, we can approach the posterior horn of the medial or lateral meniscus, because just posterior lie the neurovascular structures, and we don't want to injure this structure. But this is slightly more expensive. And then there is another technique, inside-out technique. This requires double-armed needle. These are the needles, and this is the thread. And this is more suitable for middle third of the meniscus. We take a bite on one flap of the meniscus, take it outside, and we take another bite on another flap of the meniscus and take it outside. And this becomes a vertically stacked mattress suture. And if these are placed in 3 to 5 mm distance, then it has higher superiority as compared to the horizontal mattress sutures. On top of that, the vertically mattress sutures are not going to disrupt the circumferentially arranged fibers, which are supposed for work stress distribution mechanism. This is the skin, and we make a skin incision, and the skin incision is slightly bigger as compared to the next technique here, and the knot is outside the skin and not outside the capsule, and there is no anchor inside our body, so foreign body reaction is less likely in this technique. And again, we need this device, which might be more expensive as compared to the next technique we are going to talk about. And Sachin sir just highlighted the alternating superior and inferior sutures are superior as compared to the superior only or the inferior only suturing technique. There is another technique, outside in technique. We need 18 gauge epidural needle, sutures, repair suture and shorter suture, plastic cannula. And then this is the 18 gauge epidural needle. We take a bite from outside the skin and pass it through one of the flaps here, and then pass a suture here, take it out from the cannula on the outside of the skin, make a small skin incision here, inside out, and then we tie another repair suture on the shuttle suture here. We pull this repair suture, shuttle suture outside the knee, and then take another bite similarly from inferior to the meniscus or on another portion of the meniscus. And this is the final look. The knot is outside the skin. The knot is outside the skin, and the skin incision is smaller as compared to inside out technique. This is skin, this is capsule. And the disadvantage sometimes maybe the needle is slightly bigger, so it can injure the meniscus, or they may be cut through because of this knot while pulling it outside. And this has recently been published in Arthroscopy Techniques in April by Professor Amit Joshi et al. Thank you very much for the patient listening.